Welcome to this session on pulmonary aspergillosis, where we will discuss different aspects of chronic pulmonary aspergillosis. On a worldwide scale, aspergillus infections carry substantial morbidity and mortality, with more than 1 million cases of invasive diseases per year, and numbers probably increasing due to more advanced treatment for leukemia and cancer, and so on. And chronic pulmonary aspergillosis account for more than 3 million cases a year and carry high mortality, partly due to severe underlying lung conditions. They are often diagnosed and mistaken for tuberculosis, but also for lung cancer. Aspergillus fungus are molds that grow as spore-forming hyphae, and aspergillus account for about 1/5 of the airborne spores that we are exposed to every day. But only a few of the aspergillus species that we know are common human pathogens, most notably Aspergillus fumigatus. They are saprophytes, meaning they grow everywhere in our surroundings, and we are exposed to aspergillus every day in our lives. The spectrum of aspergillus colonization and infection ranges from benign colonization to frank invasive aspergillosis. And on the spectrum, we see different forms of chronic pulmonary aspergillosis, from simple aspergillus nodules and the simple aspergilloma to chronic cavitating pulmonary aspergillosis, and on the borderline between chronic pulmonary aspergillosis and invasive aspergillosis, we find subacute invasive aspergillosis, which is generally termed a form of chronic pulmonary aspergillosis. There is a substantial clinical overlap between different phenotypes of chronic pulmonary aspergillosis, as depicted here. And over time, different phenotypes are not necessarily stable. For example, chronic cavitary pulmonary aspergillosis can develop into a fibrosing form if untreated. And on the other hand, if the host is exposed to immune suppression, a form of chronic pulmonary aspergillosis can develop into a more invasive form of aspergillosis over time. And subacute invasive aspergillosis lies on the borderland between chronic pulmonary aspergillosis and the frank invasive aspergillus disease. The development of different phenotypes of pulmonary aspergillosis is an interplay between the fungus and the host's immune response. And both immune hyperreactivity and immune hyporeactivity can lead to significant diseases. In the first case, in the form of, for example, allergic bronchopulmonary aspergillosis with a severe eosinophilic reaction to aspergillus species, and then the other end of the spectrum with immune hyperreactivity and immune incompetence can lead to development of invasive aspergillus infection. Aspergillus are opportunistic pathogens, and the risk of different forms of infections is determined by firstly immunological traits, and also by the occurrence of structural abnormalities in the lungs. Structural abnormalities, most notably bullae and cavities, predispose to aspergillus colonization and to the development of aspergilloma. On the other hand, asthma and cystic fibrosis patients often develop hypersensitivity to colonizing fungus. And invasive pulmonary aspergillosis develop in cases of severe immunodeficiencies. Allergic bronchopulmonary aspergillosis and severe asthma with fungal sensitization lies at the end of the spectrum of immune hyperreactivity diseases. They are IgE-driven hypersensitivity reactions to fungal colonization in the respiratory tract, and develop in asthmatic hosts or in bronchiectatic hosts. It's a significant driver of uncontrolled asthma on a worldwide scale and probably also an underdiagnosed disease entity. Now, they do represent a phenotype of severe asthma, and as such, they will not be covered further in this presentation on chronic pulmonary aspergillosis. Invasive pulmonary aspergillosis and chronic pulmonary aspergillosis are often considered two different disease entities, but they do represent a spectrum of invasiveness from invasive aspergillosis with angioinvasion in the severely neutropenic host over a semi-invasive or subacute invasive disease without angioinvasion, and to the true chronic pulmonary aspergillosis forms where hyphae are confined to pre-existing lung cavities. And therefore, between chronic pulmonary aspergillosis and the invasive aspergillosis, we find borderline forms termed subacute invasive aspergillosis or semi-invasive aspergillosis. The invasive aspergillosis we will not deal with in this presentation, where we would focus on chronic pulmonary aspergillosis and also the subacute invasive aspergillosis, which is often considered a subform of CPA. Common risk factors for chronic pulmonary aspergillosis consist of COPD, and especially with emphysema and bullae. Bronchiectasis are significant risk factors, as are worldwide prior TB and also NTM infections. Sarcoidosis is also recognized as a risk factor for CPA, probably to some extent due to immune suppressive treatment. Interstitial lung diseases are also risk factors, as are lung cancer. And as such, there are two hallmarks, and that is structural lung disease, often leading to cavitation in the lungs, and relative immunodeficiency, as is seen in COPD and bronchiectasis, and also in chronic lung diseases with or without treatment. On a worldwide scale, prior tuberculosis is a key driver for subsequent chronic pulmonary aspergillosis. And underscoring the importance of structural lung damage in the development of CPA, in this study, the key risk factor for development of CPA was chest radiographic cavitation, much more importantly than HIV co-infection. And the most common phenotype in these prior TB patients was chronic cavitating pulmonary aspergillosis, characterized by multiple cavities, sometimes also with aspergilloma forming in one or more of the cavities. The diagnostic toolbox for chronic pulmonary aspergillosis includes a skilled clinician to detect relevant symptoms, most often cause dyspnea, and importantly hemoptysis. Radiology is a key feature in the diagnosis. It's most often a CT where cavitation and fibrosis might be seen, but the most important hallmark is the fungus ball within a cavity. Microbiological sampling is important to confirm the diagnosis, and that is in the form of fungal cultures, but also molecular biological detection of Aspergillus species. And then different biomarkers, including IgG antibodies towards Aspergillus, but also cell wall components, most notably Aspergillus galactomannan, but also beta-glucan. The Aspergillus cell wall is a complicated structure, including different compounds that can be measured as a biomarker of Aspergillus infection, including beta-1,3-glucan, and more importantly, Aspergillus galactomannan, which is a cell wall component released in the growth phase, and it can be measured in blood, but also in bronchoalveolar lavage and in, for example, cerebrospinal fluid in the case of CNS infection. Now, interpretation depends on the sample material. When measured in blood as a biomarker for invasive aspergillosis, they yield a sensitivity of 71% and a specificity of 89%. When measured in bronchoalveolar lavage, the sensitivity and specificities are lower, but they can be used as a biomarker for pulmonary aspergillosis when measured in BAL. The process of diagnosing chronic pulmonary aspergillosis includes assessment of radiological appearance suggestive of CPA, that's most often CT scan, and direct evidence of aspergillus infection, that's most often growth of aspergillus species in culture or an immunological response to aspergillus species, for example IgG in blood. It's important to exclude other relevant diagnoses, and then it should be noted that the duration of disease in chronic pulmonary aspergillosis should be more than 3 months. And the most specific radiological single hallmark is the appearance of a fungus ball in a cavity, as is seen here. So, radiologically, chronic pulmonary aspergillosis can be subdivided into the simple aspergilloma, which is a single thin-walled cavity with a fungus ball, and the more complex chronic cavitating pulmonary aspergillosis with multiple cavities, chronic fibrosing pulmonary aspergillosis with shrinkage and fibrosis of the lung tissue, which is a late-stage disease of CPA, and the benign aspergillus nodules that is commonly diagnosed when nodules are sampled or removed due to suspicion of lung cancer. In the borderland between chronic pulmonary aspergillosis and the truly invasive aspergillosis, we find a disease entity termed subacute invasive aspergillosis. That's a disease entity that can be seen as in between CPA and truly invasive aspergillosis, and it can also be described as invasive disease in an immunocompetent host. The typical clinical picture is progressive symptoms over 1 to 3 months and the evidence of aspergillus infection. Often, Aspergillus galactomannan will be elevated in blood in bronchoalveolar lavage and sometimes also in the blood, as is a hallmark of invasive disease. Lung tissue biopsies will often reveal invasively growing fungal. And this series of pictures over time shows the development of subacute invasive aspergillosis, in this case in a host exposed to chemoradiotherapy for lung cancer. We see here a lung tumor that is being treated and a cavity is forming after treatment. Then later on, wall thickening and adjacent consolidation occurs, indicating infection, in this case fungal infection, and over time we see clinical worsening and radiological progression over a few months, which is typical for subacute invasive disease. So we have here discussed the different phenotypes of chronic pulmonary aspergillosis, including the simple aspergilloma, chronic cavitating pulmonary aspergillosis, chronic fibrosing pulmonary aspergillosis, and the simple aspergillus nodule. And then the subacute invasive aspergillosis, which is a locally invasive disease that develops normally in a mildly immunocompromised patient. And it's important to know that switching between these phenotypes do occur. For example, if a patient with chronic cavitating pulmonary aspergillosis is exposed to mild immunosuppression, for example, glucocorticoids, the disease can develop into a more invasive form of aspergillosis. Now, treatment of chronic pulmonary aspergillosis is based on administration of antifungal treatments. And overall, the azoles are the first choice agents to CPA, and amphotericin B and caspofungin are generally used as rescue therapy. In a very simplified form, it should be noted that itraconazole is generally used for the more simple forms of CPA, and with more advanced disease, treatment is escalated to voriconazole or posaconazole, and then invasive disease, amphotericin B can be administered. Do also note that generally the more benign chronic forms need long-term treatment, and sometimes ongoing consolidating treatment should be considered, while the subacute invasive forms is generally treated in as short as 6 months. And on the opposite, the more serious invasive forms of aspergillosis generally require shorter treatments of down to 3 months. So, to sum up, pulmonary aspergillosis is a broad spectrum of disease patterns, from indolent stable forms to life-threatening infections. Chronic pulmonary aspergillosis often affects immunocompetent hosts with structural lung disease, and CPA is subdivided into aspergillus nodules, simple aspergilloma, chronic cavitating pulmonary aspergillosis, and chronic fibrosing pulmonary aspergillosis. Subacute invasive aspergillosis is a progressive disease, and it lies sort of in between CPA and invasive aspergillosis, even though it is generally considered a subform of CPA. Diagnosis includes radiology, clinical features, microbiology, serology, and measurement of cell-borne antigens. And treatment is individual, with azoles generally being first-line treatments. But do consult your local guidelines, and do seek expert consultation when treating difficult forms of chronic pulmonary aspergillosis.